Good day to everyone. Welcome to track 3. This track is brought to you by Philips. I'm Liang, the host. I'm an intensivist and anesthesiologist in private practice here in Singapore. Thank you for joining us. Firstly, I'd like to apologize for the technical issues where we have been facing this morning. It's the irony, of course, that we're trying to transform critical care with technology and we suffered technological failure this morning. Now, before we begin, allow me to go through some housekeeping matters. We'll be conducting this track in a talk show format over the next 50 minutes or so. If you have a question, we welcome you to use the Q&A tab to ask your questions, and I will try to include or incorporate your questions as we move through the topic. Now, our panelists may also reply to your questions using the Q&A tab itself. Our team today is Transforming Critical Care with Technologies, and our guests are Dr. Timothy Buchman as well as Dr. Sai Praveen Haranath. Dr. Sai is an American board certified pulmonologist as well as critical care physician, working at Apollo Hospitals, Hyderabad, India, and is also a founding member of the Apollo e-Access program, which provides Tele-ICU services around India. He has a master's in public health and is a fellow of the American College of Physicians and is active on several of their committees and is the chair of the executive committee of the Council of Global Governance of the American College of Chest Physicians. He's passionate about innovation and value creation in healthcare technologies and is regarded as one of the pioneers of Tele-ICU in India. He uses the technology to provide ongoing remote monitoring and supervision of patients in critical care units in the United States as well as several rural areas of India. Thank you for joining us, Dr. Sai. Dr. Buchman, welcome to SG APICS. Dr. Buchman was our faculty and plenary speaker at SG N6 2018. In fact, we were recently reminiscing the intensely blue cocktail we shared on top of the tallest building in Singapore during our gala dinner. Dr. Buchman is a very accomplished leader in healthcare. He's a general surgeon, intensive care doctor, and virologist. Besides being a professor of surgery, anesthesiology, and bioinformatics at Emory University, where he founded the Emory Critical Care Center, he was once the president of Shock Society and of the Society of Complex Acute Illness, and of course of the largest of them all, the Society of Critical Care Medicine, which is one of the most influential critical care societies that SICM looks up to. He has also found time to be the editor-in-chief of Critical Care Medicine and Critical Care Exploration journals, and serves as a site director of a military-civilian partnership known as Surgical Critical Care Institute. He's also found time to do additional research, particularly in the areas of artificial intelligence to predict patients who will turn septic in the ICU. We're extremely honored to have both of you with us today, and thank you very much for your time, and I do apologize for the delay. We shall now officially begin. I'd like to start with Dr. Buchman. Perhaps you could tell us a little bit about your perception of the history of technology development in critical care and how it has been transformative for you.
Oh, it's a great privilege to be here this evening, and I'm very honored to be part of the conversation. Technology has always been part of critical care, and communication and telecommunication have also been part of critical care
Dr.
for a long
Buchman,
time.
yep, thank you.
I can you hear me? Can you hear me?
It's good, but it can be a little bit louder.
I'll do what I can. Hold on, and let me see if I can somehow improve the.
Yes, it's much better now.
Again, I'll hold the microphone up. I think it's not at my end. At any rate, technology has always been part of critical care, and communication is no exception. It is a fact that we have had telecritical care for almost 50 years, beginning with a simple closed circuit audio visual system that was practiced in Cleveland, Ohio in the mid-1970s. What has happened, of course, is that with the advent of the internet and extraordinary advances in telecommunication, such as we find at this meeting, we now have the ability not only to communicate with one another in terms of simple audio visual as we're doing here, but really to collect data, represent data, and provide for situation awareness in real time. That situation awareness is composed of three things. It is composed of perception of data, actually delivering the data to another human being, comprehension of the data, often by juxtaposing the data elements one with another, and then finally projecting those data into the future to understand the way in which a patient may evolve in a clinical trajectory and intervene. This is often done with presentations of graphics, sometimes with alerts and alarms, but we really have evolved to a point where our understanding of the patient does not require us to be physically adjacent at the bedside. This is actually a substantial turning point in the practice of critical care medicine. Let me pause there for other comments.
Dr. Sai, how about you? What do you think from your perception of technological development, particularly in India?
So I think just checking audio check. Can you hear me okay?
You are great. You sound great.
Very great. So, Dr. Buchman, it's a pleasure to be with you, a privilege. And thank you again to SICM for inviting us to have this talk show. I generally start all my sessions with, let's pray the gods of technology and make sure everything works. I did send my prayers out, but it looks like they want us to evolve even better in terms of technical issues. So I think that being said, critical care technology itself has evolved significantly, and I think with leaders like Dr. Buchman who have changed how we look at patients now, and how we can actually look at patients in the future with all the ongoing research. The ultimate issue is what can you get from not being at the bedside? In other words, what is it that you can get from physiologic parameters from a patient which can change how care is delivered? And I think that has been the biggest understanding. And as we learn the history of critical care, we've gone through a large number of parameters we're able to monitor. Some of them have fallen by the wayside, but pretty much it goes back to the basics. If you can understand how the basic heart rate, oxygen saturation, and blood pressure are functioning, you can add on a whole range of other numbers to help understand and gauge what can be done. And I think it's able to I think we can really improve on that as we integrate newer methods of doing things. In India, for example, cardiac monitors are often available in many centers, but many places don't have those. And sometimes you have to use very simple things like cell phone technology to actually look at patients and integrate with them. So the availability of technologies, however, with the oncoming 5G networks, that would be all that you need to actually transform care. So I think the ultimate goal of technology is to just act as a leverage to help you deliver the care that you really require for your patients. And India is, I think, in a good position right now to really capitalize on the technological advances.
I see. That's interesting. Is 5G network already available in India yet?
So
Okay.
in very limited areas, just as in other countries, but it is definitely on its way. Fiber optic networks have extended quite a bit also now. So all of those are, I think there's a huge amount of infrastructure being put in to make those available.
Okay. Thank you. Dr.
Not
Buchman?
sure. I'm not sure that the bandwidth is the issue. I think that from an operations standpoint, what we find is that getting the right data to the right person at the right time, sufficiently refined and processed so that a decision can be made, is far more important than the difference between a 4G and a 5G network. Even with a relatively narrow bandwidth and even with lag, provided the person at the other end of the circuit can understand and make an appropriate decision, that usually can be done on relatively sparse data processed locally. Over.
So you mean that you can, for your model of telemedicine or EICU, do you get a continuous stream of data, or is it an intermittent type of model?
Our model is a continuous stream, but it can run over a traditional T1 line and do so perfectly. We have fiber optic, of course, now, but even older technologies are sufficient to deliver the consistent waveforms and data feeds. Again, I don't think it's the bandwidth, and I don't think it's the speed, because we can deliver care from the other side of the world in Australia back to the United States. It really is a question of giving the right type of presentation to the clinician who's trying to render distant care. Over.
If I might, I completely agree with Dr. Buchman. The technology, you really don't need high speed to deliver care. In India, though, there's a leapfrog happening where places don't have cardiac monitors, they don't have intensivists. So in that kind of a setup, having a faster network is going to change how care is done, because I think the phones are going to ultimately end up, maybe they might even gather clinical data, and you may be able to use the widespread mobile network itself to deliver care. So I absolutely agree with Dr. Buchman that we can operate on very slow networks. We have places connected with 2G where we can actually look at the cardiac rhythms and everything. So that it's highly possible. Yeah.
So I guess as a summary, we could actually say probably the hardware is not really the limitation, but much more of a system. And
Absolutely.
that you need, how does the model in India work in terms of having the provider? Who do you need at the other end of the computer screen to be helping you deliver your care?
Sure. See, there's many, critical care leaders, I think maybe Dr. Buchman have said this too, and Dr. Safar in the past, that critical care is not a place, it's a process. It's really about delivering the kind of necessary emergency measures and ongoing care to patients with abnormal vital signs due to disease. And in India, for right now, for example, we are connected to some very rural areas. And for example, we run a emergency COVID management system we started a few weeks ago, in fact, where these are located in places where there are forests and waterfalls, where there's hydroelectric projects, thermal projects, where they don't have anything else. They have a small setup of a hospital, and we are connected to them to guide them with their COVID management. And these places are relying on reasonable bandwidth, but it's not great. But in terms of how we actually do it, we have remote sites all over the country, and we have all the data we require. The people at the other end are either basic medical graduates with some element of training, or they might be anesthesia doctors for the hospital who are now being roped in because they have to do all these other tasks. So typically they never had a critical care setup. Typically they would shift patients out after an initial stabilization, but sometimes this journey would take them 7, 8, 12 hours sometimes by road, and air medical transport is not widely available. So these are the limitations in all of Asia. For example, in many developing countries, transportation issues and infrastructure issues are a possibility.
I see. How about Dr. Sai? Can I just ask you an additional question? How do you teach the person at the other end of the computer screen to use the technology?
Oh, absolutely. So see, that might be one of the biggest benefits having connectivity, is to actually educate them on everything right from the start. So when the COVID crisis started, my hospital group decided that we need to educate critical care to basic critical care and basic ventilator management in preparation for possibly having the need to use these around India. And we've actually, by now, about 20,000 doctors have been trained in using ventilators through a basic course that we did. And we just use training for basic medical graduates and nurses. Now, these are things which we didn't even think about in the past, and we didn't even think that we could even be able to do this kind of training. Anytime we connect a site, though, we have a onboarding process where we give them a physical classes where we go there, or we invite their team to come to our ICU, spend maybe a couple of weeks to kind of get an orientation and make sure we're all speaking the same language. And we don't connect to sites which are unable to provide that basic minimum thing, because without communication, none of this works. So we bring them so they are up to speed on what are the basics of critical care and management.
I see. Okay. Dr. Buchman, how about the American experience? I guess the fact that is most people are very familiar with the computers and technology and probably will have no problems. But how do you get people onto the same platform speaking the same language? How do you relay what you need?
Yeah, it's a very important question, because the application of this telecritical care, or Tele-ICU, the former episodic consultation, the latter continuous support, really does depend on who's at the bedside. And in fact, it is always a workforce solution. We don't have enough doctors, hard as it is to believe. Doctors of any stripe are in short supply at the bedside of many ICUs. So in the United States, we've turned increasingly to advanced practice providers. These are physician assistants. In some cases, they're specially trained nurses with additional cognitive and procedural skill, and they become our eyes, our ears, our hands at the bedside.
I see. I'm curious to find out how exactly funding works for you in terms of providing the hardware and the training in order to use the platform. Dr. Buchman, how does it work for you guys?
So it's an excellent question because, of course, care costs money. And in the case of critical care or Tele-ICU, it costs even more money. The approach that we took was to obtain a federal grant, a government grant, to enable us to get started with our program. And we were able to show not only did the quality of care increase, but the total cost of care for the patient decreased. It decreased because we avoided complications. It decreased because we had shorter lengths of stay. It decreased because we had fewer unnecessary procedures and tests and transfusions. And the patients went home healthier with fewer readmissions. So when one calculates the value proposition and figures out the financing, it's got to be more than the cost of the equipment and the cost of the staff. It has to be an examination of the total cost of the care of the patient.
That sounds like you need a lot of baseline data. Is that how you started the Tele-ICU service in your university or your hospital?
Yes, it's very important to understand your current procedure, your current need, and your current gap. Simply dropping technology in from the sky and saying, here it is a recipe for disaster. There has to be a common view of what gaps exist and a common desire to fill those gaps in. And only with an understanding, an unblinking look at the problem, can one begin to formulate a solution and ask how any technological advance, whether it be remote critical care, a new device, a new drug, how that fits in to help globally the care of the patient.
I see. Now, in Singapore, we do not have any Tele-ICU, and I'll be interested to know when you first had the idea of using technology to do what you do right now, who was the first person that you had to get buy-in from?
The first person I had to get buy-in from was myself, because there is a tendency in critical care and in medicine generally to say, we have always done it this way. It is very disconcerting to imagine that one can deliver quality care without physically being at the bedside. And it means that one must embrace the concept of team care with task reallocation among individuals and across distance. The first person who has to believe in it is the person who's proposing the idea. It can't be an add-on. It has to be part of a belief that critical care, like so many other branches of medicine, has to evolve. Now, once it begins to evolve, the most willing partners, the people who will come first, are the people who are struggling. That doesn't mean it's the people who need it the most. In fact, our greatest impact was at the big university hospital, not the rural hospital. But it was the rural hospital in exactly the sort of situation that you've heard about in India, where there are sick patients at long distances from qualified personnel who are begging for any sort of help. And they view this type of support as a godsend.
I see. So going to India, I'll just transit over to Dr. Sai and ask him, Dr. Sai, you have never met these people at the end of the computer screen. How do you establish trust? How do you get them to believe in what you are saying, what you're proposing? How do you get to basically form a degree of coordination and basically team formation? How do you establish it long distance?
Sure. See, I think, like any long distance relationship, you need to be cautious, you need to be honest, and you need to overcome a lot of barriers. And I think one of the issues is when you form a relationship, sometimes it's based on a financial need where your system needs to get business. The other side needs assistance in managing patients. So it goes back to the basics of really making sure that there is a need that exists. The second thing in terms of the trust building involves actually going to the site and visiting and interacting so that you have a network of a champion at the other end who's going to actually be able to promote the cause and be able to assist with convincing others that it makes sense. And you should never get into it if it's not going to work out. In other words, if there is a lot of resistance, you should really not do that because you need people at the other end to be able to participate in the care process. And it should never appear like somebody came and did this to them. It should never appear like somebody else wanted them to do it because it'll never work that way. And we have started in some places, to be honest, where we thought it would work, but it didn't because either they were not interested or their workload was so heavy at the bedside, they couldn't really do the extra processes. So one of the things we need to do is really figure out a way to integrate the workflow so that it's not a new thing they do. It needs to be part of what they do every day. It may be a little change from what they normally do. And trust building really takes honesty in terms of saying what you can and cannot do. You can't guide a central line remotely. You could in the future, but right now you can get a central line. You can give people who don't have the skill sets to do something new right off the bat. So it's not like disaster medicine where somebody has to do on the spot new things you've never done before. So there's a lot of time for planning, especially in a center which has a lot of expertise. So we actually send our teams out every month to do physical classes. The team from the remote site comes into us, and we also make sure that there is a weekly call at least to make sure that any problems are sorted out before they become worse. And I think it's very important to be transparent in terms of what you're actually doing for them, and also have a backup system for the telecommunication part so that in case there's a failure of one network, the other one works. And that is an important thing, especially when people start to rely on you. So after a few months of working, they start relying and saying, you know what, the Tele-ICU will manage this for you. And if you're not available for whatever reason, then that can harm trust. The other factor is there will always be naysayers. There will always be people who say, you know what, it didn't work. You could be doing it great for 5 years, then one day something happens and one particular doctor who doesn't like the system says, you know what, this is not working. That's like any relationship. So we need to figure out a way to kind of work through those and ultimately realize that we are in it for the patients. I mean, we're in it to help patients who cannot get the care that they need, and you're giving it to them. And ultimately, in my estimation, 80% of what can be done at the bedside can be done remotely.
Could you maybe tell us, if you don't mind sharing, what kind of, or do you have a case example of a difficult relationship you have with of another site?
Sure.
Why did it not work? And
Sure.
only if you're comfortable sharing that.
Okay, so there are sites where not just in the Indian model, but as I mentioned, I do it for the United States too in many areas. And some of these are very rural areas, as Dr. Buchman said. In fact, the data says that 50% or more of ICUs in the US are in remote rural areas, and a third of all ICU costs hospital costs are from ICU. So it's a pretty big business in terms of the amount of work involved. So there was a situation where the antibiotics were changed without telling the provider. And it was an appropriate change, but the provider had chosen those particular antibiotics for a particular reason. And it was something that was not communicated. And it was more of a failure of communication rather than an error. But that created a precedent that, you know what, you guys are doing things without telling us. And that led to a snowball effect. And unfortunately, we were very preliminary in our startup phase where We didn't understand the whole thing yet, and that created issues. However, we were able to reestablish connectivity after discussion and talking, but these kinds of things can kind of demotivate the teams. And in the Asian setup, India and Asia, there's a lot of, I'm going to be honest about this, egos of physicians. People have a territorial aspect where they feel like this is my patient, this is my unit, this is my hospital, this is how things are done, which is where right up front you have to crack the ice there and make sure that you have a two-way dialogue going and people realize you're on the same team. You're not overseeing, you're assisting, and the patient and the bedside doctor are on the same team. And that works wonderfully in multiple systems that I actually do care for.
I see. Dr. Buchman, any experience on
That's
your
true
side?
around the world, okay? That the message has to be to the team at the bedside, they're in charge. We who are doing remote care are there to support and not to supplant the team at the bedside. Our best job is, our best outcome is when we make that bedside team look good. And the importance of communication can't be overemphasized. Most of the work that people think goes into setting up this telecritical care system is the hardware and the software and the cameras and so forth. But the most important work is ensuring that there is a sign out, sign back, and strategy for reaching people on the bedside team whenever and wherever the remote intensivist notices that something may be amiss. Almost every problem that comes up in terms of trust, in terms of outcomes that could have been better, can be traced back to a communication problem. And one of the first things I say when a new hospital invites us to consider working with them, say, we're going to be developing a relationship. The product of the relationship is going to be the remote care, but the remote care isn't the relationship itself. The relationship is something that's built on learning the culture, learning the capabilities, learning the gaps, and figuring out how we work together for the common benefit of the patient.
Yeah, it sounds like if you were presenting yourself as a form of assistance as opposed to somebody taking right over, you'll probably get a better buy-in. Am I correct to say that?
You are absolutely correct. I believe, and I tell all of my staff, there is no task too small, no support that you can give that is so minimal that it won't be appreciated. So whatever is needed, do it. Whatever you're asked to do it. And then look at the situation and offer a different perspective. Never say to somebody at the bedside, you're doing it wrong. Say, I've noticed the following. What do you think? It really is a matter of establishing those two words, trust and respect.
See, from what you have just mentioned, it sounds like you do use Tele-ICU as a form of a method of education as well. Do you find it useful?
Not only do I find it useful, the nurses find it incredibly useful. In our environment in the United States, much of the demand for telecritical care, tele-ICU support, is during unsocial hours, nights, weekends, and holidays. Those shifts are normally taken by the most junior nursing staff and sometimes the most junior physician staff. And in a sense, it gives them a certain amount of pride and confidence to be able to call us in the Tele-ICU center and to show their colleague that they are, willing to go get information. Sometimes when you're asking the person next to you saying, I don't know something, it may feel embarrassing. But if they call the Tele-ICU center for the latest information, well, that shows that they are a learning professional.
Yeah,
so we can use the relationship actually to build trust and confidence.
I'm just having this picture come up in my mind where you have an intern in the ICU and you have a question and you turn on your system and Dr. Buchman's at the end of it all, trying to tell me what to do, I think I'll be incredibly reassured.
The thing is, I won't ever tell you what to do. I'll say, what do you think? And have you considered the following?
Okay, I see.
Okay.
So I'm just
And
wondering, is there a particular type of quality with regards to a critical care physician or provider? Is there certain characteristics or attitudes or attributes which will make one person a better tele-ICU provider than the other, besides having, of course, the belief in the model?
Absolutely, but I'm going to let my colleague in India speak to that question first, because he serves people in so many different environments, yet he brings the same characteristics.
Thanks, Dr. Buchman. Thanks, Dr. Tan. I am now into, I think, 11 or 12,000 hours of doing this for the last few hours. If you look at aviation, you look at flying, it's like that kind of number of hours. And what I've realized is that I kind of ask myself, do I really enjoy this? And I think about it and say, you know what, I actually do. And the kind of physician who would enjoy this is somebody who likes problem solving rapidly, talking to people and helping them, especially when they're in the middle of an issue, dealing with it's pretty amazing. Every time I sit back in the middle of a shift and think, oh my God, I'm on the other side of the earth and I'm actually able to help somebody on the other side. That just fascinates me. And I think the other part of it is to be able to teach somebody. Ultimately a doctor is a teacher. And when you can actually teach somebody to take care of a patient, my goal is to get rid of the Tele-ICU in a few years in that site, because you're going to increase the learning curve of the local team so much that there are several things they may not require. And those are things which motivate me to actually do it. So I look at my colleagues who get into this. We should not undermine the fact that this is a financial decision many people take because of many reasons, where it's decent income for doing good work. It can be very busy at times, but it's a good decision. It's a good career choice for many people. And the way to really look at who would fit this in is somebody who enjoys the bedside, but enjoys teaching, enjoys the fact that technology can make these changes, but also wants a little bit of a breather from being at the bedside to kind of recharge. Sometimes tele-ICU shifts help you recharge to kind of get back to the bedside. So I feel like someone of that nature would be helpful. Now, there have been instances where we have supervised very complex procedures. I do pulmonology too, and there was a situation where somebody with hemoptysis, and Dr. Buchman said, a junior fellow on staff, the clot wasn't coming out. So I had to guide the doctor the other end saying, okay, do this, do this, do this. And we got it out. And, we have guided all kinds of things remotely. It can be done. Now, again, it is not wartime disaster medicine. The US government has done remote surgery. We're not talking about that. We're talking about bread and butter critical care where you can make a difference. I teach nurses how to do the passive leg raise, and some of them have never heard it. And you can teach these things virtually, and this will help them in their bedside care even when you're not online.
So the phenotype of the successful tele professional is someone who is not focused on command and control, but someone who likes to coach, someone who gets satisfaction out of supporting other individuals, someone who's truly a servant leader. It is absolutely correct that when you're looking at 170 different patients, which I have done from time to time, you have to be able to juggle multiple priorities and convey to whoever you're speaking with the image that they are your only concern for that particular moment. So there are strong analogies to aviation. You have to be able to think in multiple dimensions simultaneously, and you have to be humble and recognize that the physiology of the patient and the physics of the airplane are things that you have to work with, not fight against. At the end of the day, you have to find real joy in helping others feel good about the care they've delivered.
Really profound. We were talking about technologies, but we seem to realize that the soft skills, the human interaction, actually is quite fundamental. It's not about the hardware; it's actually where your heart is. It sounds like it's not only just healing for patients; it's also potentially healing for the staff as well as the doctors and providers. Now we are in the COVID-19 pandemic, and there's no escaping having to have a discussion. I would like to ask both of you how you found Tele-ICU in this particular instance of time. How has it helped your practice? Do you think that it has evolved, it has forced evolution or accelerated the use of Tele-ICU because of the current situation? Dr. Buchman?
I'll be happy to take that one first, and let me go ahead and share my screen here for a moment and see if we can give you a little bit of a picture. Hopefully you are now seeing my screen where it says COVID-19.
Yes, we are.
But this is the care landscape that we were facing in the United States. I work down in Atlanta, Georgia, in the southeastern portion of the United States. And the graph on the right shows the number of cases. We had an initial first wave from April and May. We had a little lull in June, and then you can see in this period from mid-July to early August, we had a significant ramp up of cases in the state of Georgia. Well, this led to a significant increase in the demand for shifts to be covered. We use our advanced practice providers, and during the period that I'm showing you here, it wasn't 1,381 additional hours, it was 1,381 additional shifts that were required to cover patients within Emory. Now, we're not covering all of them, but you can see at the red arrow the sharp increase in the number of shifts that were required. Most of these providers had never seen a critically ill patient before. So what happened to our EICU daily census? We went from an average, this isn't peak, but over a month, we went from an average of 104 to 151 patients. That's about 1.4 new patients in those beds each and every day. We had no new EICU staff for this 50% increase, but at the same time, the bedside staff, that button on the wall, they were pushing it at a rate 3 times the rate they were pushing it in the previous month. So the expansion was exceedingly rapid. And the bottom line is that the demand for care could be flexed up because we have the ability to reallocate tasks and responsibilities in real time. And that's really the great advantage of Tele-ICU. We can keep redistributing and reallocating tasks among different persons so as to service those in need as soon as they are in need. Over.
Oh, Dr. Sai, how about your experience?
So we have actually started doing COVID care for our own hospital, where we initially we set up a separate COVID entire area of about 100 beds of which could be ramped up into critical care or basic care. All these patients ended up getting monitored with videos as well as vital signs monitoring. And the benefit we saw was that we were able to actually get the care to the patient faster, especially if there was a donning doffing time issue. There were situations where a patient on BiPAP pulled it off, and we were able to rapidly prioritize who goes in and also coach patients on the awake proning that they needed to do. So we were able to do these physical things which the patient needed to do and also offer a way for them to keep talking to somebody, because sometimes there's isolation, especially there's a no visitor policy, and that was an issue that people were facing. Of course, they could talk to their family in video, but it was helpful for them to know that there was somebody watching them. And there's a lot of fear factor about the whole disease, and be able to reassure them that things were going well. On the other end of the spectrum, we had patients with very severe ARDS, and both in India and the US model that I see, and we were coaching on proning and doing the entire PEEP titration as well as doing real critical care. And the volume of work was huge. I mean, there was one day in April, I was monitoring a system in the southeast of the US, and I was overwhelmed emotionally because I saw on my list 140 ventilated patients. And it was, I'm like, oh my God, it was a feeling like, wow, this is not a good thing. And I was thinking, if this happens in India, this is not going to work at all for us. Fortunately, it has not gone to that stage in any one center. But what we have also done is to try to get critical care ramped up, the basic principles. Okay, as I mentioned earlier, the ventilator management. So there's a lot of education happening. And in a way, COVID has done a lot of positive changes where people recognize that critical care is important. People recognize that intensivists actually, they are not resident doctors. And there's also the fact that Tele-ICU and telemedicine especially has ramped up a lot. There are many COVID patients who are being managed at home where we're actually helping them out through our telemedicine techniques. Now, the other side of it is in the US, in the Indian model, which I mentioned earlier, where we had the remote ICUs in these rural areas, even they are having to handle COVID patients and they have not handled anything this sick before. So we are making a huge difference in guiding them in basic principles. Now, India, as you know, is a tropical country. The mosquitoes haven't gone away. So we are having the malaria, the dengue, everything else added on top of COVID. So it's important to recognize that the burden of disease is still pretty high. If I might quickly share a couple slides, may I do
Yes,
that?
please do.
Okay, let me see if it works. 1 second.
While we are waiting, can I just ask Dr. Buchman, do you actually interact with the family of the patient while you're using?
Absolutely. It may be a shock, but I have had end-of-life goals of care discussions with families, and I've had those discussions not just over the tele circuit, but in fact from the other side of the earth. I have worked with families to listen and respond to their concerns and their decisions, and actually changed from aggressive care with curative intent to comfort care in Atlanta, but I'm delivering that care from Perth, Australia. So there is no limit to what can be done in terms of communication. One might imagine that families would be resistant to speaking to a physician on a headset as I'm speaking to you now. But in fact, this has now become part of our culture, part of our way of life. Particularly younger family members are very comfortable with this sort of communication. And in fact, the opportunity to speak to a senior physician on demand when it happens to be 2 o'clock in the morning at the bedside of a sick person, families find very reassuring. Over.
So I just put up a slide. Is it visible to you?
Yes,
Yes.
it is.
So this is just a montage of different slides. I pulled the images together. So we are obviously in day 298, and you see a WBC with the COVID virus there. That's a picture of my hospital. On the bottom, you see a quick image of what we see, where we see the patient, the cardiac rhythms, the data stream that's coming through. And my image of this COVID warrior, taken from some emojis from the standard software, is that, you have to sometimes look at things differently. You have to look at the world differently to try to figure this out, because you can't do work as it is, because we have to innovate at this point. That's a mosquito to remember. And I feel that the cost of care is very unreasonable still for critical care anywhere in the world, and there needs to be some rationalization of how to actually deliver it more equitably. Are doctors the problem? In other words, are we having physicians, are they resistant to change? Maybe, but the more and more I see it, especially in the COVID pandemic, people are very willing to adapt. I mean, everyone's using video calls for everything now, so people are very willing to adapt. And the aviation analogy I mentioned earlier, in our system is called the e-access system, and I believe it's critical to care, and that's kind of why I got into this. And anytime you're trying to scale up something like this, you need to have an incentive, you need to innovate, overcome the interference, and also have institutional support. And this slide of mine about the communication piece, I can't overstate it, because I really think critical care and tele-ICU is all about communicating and using the data and the evidence to really make a difference. So this is just one of those slides. And then I'll see if this video plays for you really quick. This is our Indian center, where you can't hear the audio, but we're able to actually get the alerts on the patient. This is very different from what I do in the US model. So I have this schizophrenic thing where I switch the US model, where I'm doing these things where the nurses know everything that they're talking about. And I have this other model where I have people with very minimal training who have to coach and do things. And there's been a lot of learning in both directions, honestly, where there are some things where the nurses are asking for something and tell them, there's a lower cost option. Why don't you do oral acetaminophen rather than IV acetaminophen, which costs so much more. You don't really need it all the time. And we have our doctors who are actually monitoring these patients and are able to do that. We typically can, we have a 24/7 system where we have the nurses and the doctors doing it. And this is a video of one of our doctors coaching an echocardiogram to a place where they never did echoes. And in India, you need special permissions for using ultrasound machines. So we had all that. And then he can evaluate the RV and the LV and figure out volume status. I mean, do all that at the bedside. And there are models now where health providers are able to use an ultrasound probe, and you tell them, hold it left, right. I mean, it's a toy, it's a joystick ultimately. And then, the mosquito again, and this is the slide. And I believe this strongly, that you never stop learning because life never stops teaching. And every day you learn something new when you do this. So I just want to kind of quickly share this very brief montage of slides to kind of talk about, where I come from in terms of why we do this. Going back to your original question on the COVID crisis, I think the Tele-ICU and telecare is absolutely here to stay. We haven't talked about your region. Now, Asia Pacific, for example, China, the telecritical care is going to ramp up much more rapidly than anywhere else in the world. And there's going to be a huge need to deliver this care. And I think the language barriers may need to be addressed when you're looking at this. That may be the one issue that we may have to have better ideas on, although you can use technology to solve that too.
I see. So we have come close to the end. I would have actually loved to tap your ideas and experience further to ask you more things such as the medical legal aspects, but I'm afraid because we are running out of time. I think I'd like to thank both of you for joining us, and I think it would be appropriate for me to make a summary. And I would think that essentially what we are saying that technology can transform critical care, but certain fundamentals don't change. Team formation and communication remains key. And we can use EICU or Tele-ICU in ways not just to help patients, but to help providers in terms of education. It could be healing itself. And it allows for very dynamic shifts of manpower to where it's necessary, regardless of time zones. And that's my takeaway from speaking to both of you. And I wonder whether there's any additional last advice or pearls of wisdom you would like to share with our audience. Dr. Buchman first.
I think that what we have seen is the evolution of global critical care. The ability to reach into the next ward, into the next hospital, into the next city and country and continent, to reach around the world to bring expertise where it's needed is quite extraordinary. And if we can only get past more of the geopolitical barriers, more of the uncertainties, more of the concerns about who owns the patient, and recognize that everybody needs help at some point, this will become, in 10 years' time, not an exotic technological thing, but really foundational in the way we care for patients 24/7 by 365.
Thank you, Dr. Buchman. Dr. Sai, any last comments?
It's very hard to go beyond what Dr. Buchman said. That was very beautifully stated, Dr. Buchman. But I very strongly feel in my heart, honestly, that we need to do everything we can to take care of people wherever they are. Every other barrier really doesn't matter. And that's the fortune that we have as physicians, to be able to care for a human being wherever they are. They're all the same model. Now, ultimately, the other part of it is to think about critical care as something that we can deliver with efficiency. There are people who require this, who have no other access to this unless you're there. And we are able to actually transform their lives. The life of a husband, a brother, a wife, or a daughter, or a son that is saved because of a simple measure like giving IV fluids rapidly. I mean, think about the transforming power of that. And telecritical care is ultimately critical care. It's just given through some other technological, intermediary. So ultimately, it's about giving care.
Thank you very much for both of you. We've come to the end of our discussion of Talkshow with regards to Tele-ICU. I thank both of you for your time. Sorry for the late start, but we'll move on with the show. I will be in touch with both of you again certainly to learn more things and see whether we could set something up in Southeast Asia with your advice and guidance. Thank you for joining us both.
Thank you so much for having us. Take care.
Bye there. Next up, I would like to introduce to you Dr. Gert Hüske-Kraus. He's a clinical director of clinical consulting in education in Philips Healthcare. Now, Dr. Dirk has intensively engaged in research around this concept of alarm fatigue and alarm management. And he has also done a recent government-funded project called Alarm Redux on the topics about measuring alarm system quality and safely reducing avoidable alarms, as well as new ways of fighting alarm fatigue. Now, he has done many projects, and he has been with Philips for many years now. He'll be talking to us about alarm fatigue, the unknown pandemic. And I don't mean to alarm you, but I also just learned that it has impact on patient safety and also on the staff health and safety. Dr. Kirk, I'll hand over to you now.
Yeah. Can we do a quick sound check? Can you guys hear me okay?
You sound perfect.
Okay, that's great. So thank you very much for the kind introduction. I'm happy that we finally could make it. Let me just share my screen. This should not take all too long. So here we go. Yeah, I'm going to talk about alarm fatigue, the unknown pandemic, and I can skip the first slide because you already so kindly and comprehensively introduced me, and ask you that at least for the time of this talk, we regard alarm fatigue, as has been suggested by the title, as a disease. Let's describe it as you would describe a disease, look at the definition, at the epidemiology, at the etiology, and so on. But in introduction, I'd like to switch from the clinical side of things, at least for a minute. Yes, of course, alarms are a good thing. After all, they save lives, right? But they have some detrimental side effects, which can be disastrous. For instance, the catastrophe at the Deepwater Horizon was severely aggravated by the fact that a general alarm was sounding all too often, waking up people at midnight from false alarms, so they habitually disabled the alarm, which led to the catastrophe here, killing 15 people and a huge pollution of the Mexican Gulf. A similar thing, Ladbroke Grove train accident, killing 30 people, injuring 500. The investigation revealed that train drivers, again, as a conditioned response, acknowledged alarms that would warn of approaching trains, which not in all cases, obviously, are false alarms. What we're seeing here is kind of a chronic overload of alarms that lead people to react inadequately to alarms. But there is a second flavor of alarms. Looking back at the 3 Mile Island incident in nuclear power plant, during this incident, people were exposed within a short time range to more than 700 alarms. So people knew they had a problem, or 700 thereof, but they couldn't get to the heart of the matter. They were just overflown with alarms in a manner that you could call an acute overload by alarms. Now, obviously, the question arises, and that's the rhetorical question for sure, can something like this happen in clinical medicine as well? Well, the answer to that is obviously yes. This is an example from an analysis after an adverse event where it shows that from the alarm log, within 30 minutes time, 11 assistally alarms have been acknowledged by staff from the central station for a patient that obviously was in a systole. You might say this is an extreme case, but let me assure you it's not. If you look at the press reports, there are many of them where people died after a nurse deliberately shut off the alarms. That's another one where the patient heart rate fell over 20-minute time span, but the audible crisis alarm was turned off. Same hospital, a few months later, the next patient death, and again, nobody could hear for nearly an hour the critical alarms. I could go on and on, but I'd rather change your view of what inadequate response to alarm might also mean. This is from a young, healthy patient in mouth surgery that had a sudden drop of SpO2. They replaced the sensor, then still got abnormal values, called for another oximeter that also appeared to be faulty because it gave abnormal readings until the patient was in hypoxia and induced cardiac arrest. So also not believing the values that you see, not believing the alarms can also be a kind of inadequate reaction to alarms. I could go on and on. I'll spare you all the cases, but rather focus on a few basic facts regarding alarm fatigue. The literature tells you that caregivers are flooded with up to 350 alarm conditions per patient per day. In our projects, we find even higher numbers, and that's just counting monitors and ventilators, not perfusion pumps, not all the other devices that you might have connected to patients. And all these devices compete to capture staff's attention, sometimes really leaving them in the dark as to what needs to be done. Most of those alarms, and that's an important fact, do not require any action by the caregiver, depending on the unit. Between 80% and 97% of the alarms are non-actionable. And of course, in this alarm flood, life-threatening events can be lost, but there are some other detrimental effects that I'm going to explain in a minute. Let's first settle on a definition. What is alarm fatigue? You will find as many definitions as you will find sources. I'd propose to go with this definition, that the alarm fatigue is a condition of not so much an individual caregiver, but rather of the entire social technical system ICU, where a history of too many non-actionable alarms have increased the probability of staff to inadequately respond to alarms. So this definition has at least the upside that it doesn't pathologize people, but it looks holistically at the system ICU, and it makes also alarm fatigue to a degree measurable. Let's proceed in the description of the disease, quote unquote, alarm fatigue, and let's look at the epidemiology. Basically, it's largely unknown. We have anecdotal evidence from studies and press reports like the ones I've been showing. There are some figures like the FDA once reported 566 alarm-related patient deaths. Just think about this term, interesting term, in the US within 5 years, but all the experts agree that this number grossly underestimates the actual numbers. We have no idea how many patient deaths there are, and we have no idea how many adverse events, near misses there are due to alarm fatigue. But we begin to understand the pathophysiology. What are the consequences of excessive alarms? So the trivial thing is excessive alarms stress and irritate staff, which of course has an impact long-term on staff health. They also create, that's trivial thing, unnecessary workload, which together with stress and irritation lead to staff satisfaction and might increase the staff turnover. Alarms also disrupt care processes. After all, ICU nurses are not just idling there waiting for alarms to happen. And those disruptions, together with the unnecessary workload, add to the operational inefficiency of a hospital. But those disruptions also create errors when people resume their interrupted tasks. There are studies that say that when you're doing medication-related tasks, the probability of making a mistake increases by 25% with each interruption. Midterm, we've seen a few examples of that, clinical and non-clinical. Staff becomes desensitized and overloaded by alarms, which then leads to inadequate reactions to those alarms, a few examples of which we've just seen. So both those inadequate reactions and the errors and omissions are adding to adverse events and complications, and are two sources of a threat to patient safety. But there's more to that. Alarms add to the general noise pollution on the ICU, which not only increases patient and relatives' dissatisfaction, decreasing reputation and trust in the institution, but of course those noise pollution disrupt patient sleep and their circadian rhythm, which adds another factor to the probability of an ICU delirium developing, which is the third threat to patient safety from non-actionable excessive alarms that you see. This is pretty much what you can see when you look at the literature, and this is pretty much what you can see whenever you walk into a non-optimal ICU, wherever you are in the world. So let's go from pathophysiology to etiology. What are the root causes? Because in the end, we need to look at the causes and at the root causes. And there are many of them. They have to do with the infrastructure of patient surveillance. They have to do with the environment the staff works in. They have to do with the consumables that are being used. They have to do with the configuration that's being employed, and all those arms here you could again look into detail and find more subcategories. But for me, always the most important ones are the last two ones: the workflow aspect, the processes, unclear processes, ill-defined processes, low compliance to processes. And you need to look at the team, their competencies, how they cooperate, how they collaborate, how they are being organized, their habits, their attitudes, their discipline. Those are things that you will invariably find in units with the bad alarm management. So seeing these etiological factors and pathophysiological factors, is there nothing we can do about it? Well, obviously there is. If you look at the literature, you will find rather high numbers of alarm reductions, 43% of alarm reduction by rather simple measures like making staff individualize the thresholds to the patient status, using delays, and so on. And I could also cite an example from Philips, where we were able to reduce in a sustainable and in a safe way non-actionable alarms by 40%, increased staff satisfaction, increased patient satisfaction. And if you just look at the time of resources that we were able to free up, did a back of the envelope calculation that ended up with 0.5 FTE that we freed up to do more sensible things than acknowledging non-actionable alarms. So if all this is the case, if you can be so successful, why are we still in a status where if you ask nurses about alarms and the problem, they see it as a clinical and, by the way, also an economic problem, and they refuse to take this just for granted, but generally they don't think it's an easy problem to solve. And a similar thing can be said about the physicians. They think it's a significant danger to patient safety, but when being asked, does your institution have a clear program? Do you have a clear way forward to address this problem? They tend to be unsure as to what the plan of action would be, and only very few institutions have a clear, concrete, and stringent plan to address this. Why is that? Is there no good advice on what you should be doing? Well, you might say there is. There are recommendations by the American Association of Critical Care Nurses for the AMI, but if you really look at the details of what these recommendations are, they leave a lot to be desired. They tell you you need to analyze the data, you need to share the data gathered from the analysis, you need to assemble an interdisciplinary team, you need to determine the clinical significance associated with alarms. All this is fine and well, but it doesn't give you concrete, actionable things what you need to be doing with a unit that you are looking at, where you have a strong impression that the alarm management is suboptimal, may be triggered by an adverse event that is likely due to alarm fatigue. So those recommendations are very generic, but they don't actually help you in solving the problem. And I think this lack of actionable advice is an indication. It's an indication of a blind spot that we're having, and I'd like to illustrate that with two famous quotes. The first famous quote by Franz Vollhardt: "The gods have placed diagnosis before therapy." Let me break it to you. There is no silver bullet. There is no be-all, end-all therapy to the problem of alarm fatigue. Rather, you need to establish a diagnosis. And if you think about all the number of causes and root causes that I've just shown you, the mix of root causes responsible for the situation that you see in a unit is different from unit to unit. Even two adjacent units under the same management may have complete different root causes why they're experiencing problems in their alarm management. So you need to diagnose, you need to understand before you actually trigger therapy. That's a trivial thing to say to clinicians, right? But if you look at the publications, you almost never find a clear diagnostic step. And the next quote is by Edward Stanning: "In God we trust, anybody else bring data." Meaning you shouldn't be basing your diagnosis on gut feeling, on subjective impression. You need to base it on data, on facts, on numbers. And they can be achieved, but it's not easy. How do you do a diagnosis based on numbers? If you look at the metrics used to measure alarm system quality, you will find things like the alarms per monitored bed day invariably in any publication. But if you apply some simple criteria for measuring metrics, like content validity, does it indicate a root cause or the effect? Is it comprehensive? Does it allow pre-post comparisons and so on? This metric, as well as the other metrics, don't fare well, leading to a situation where, and this is taken from a real project, where you have in the pre-post comparison a slight increase in alarms per patient per day. So that was a failure, right? But if you look at the cumulated alarm durations, you see a decrease by 83%, which certainly is a valid measure as well, you might say. So was that a success? Was that a failure? Obviously, a single number doesn't describe a complex phenomenon like alarm system quality adequately. Again, that shouldn't come as a surprise, but still, if you look into the publications, you don't see much attempt to define better criteria, though you will find in newer publications the expressed desire to come up with better metrics. Again, still staying with diagnosis, clinicians are used to do pattern recognition for diagnosis. So when I showed this breakdown of alarm types on his unit to a lead physician, he asked me, is that a good or is that a bad thing? Of course, he wouldn't know, but if you compare it, if you benchmark it against other units, one thing strikes you immediately as odd, and that's the large proportion of red alarms. And if you add to that the numbers, the absolute numbers, then it becomes perfectly clear that 92 red alarms, critical alarms, life critical alarms per patient per day, something must be wrong here. So this is the kind of indication where you say, okay, I know at least one of the problems that I need to deep dive on, and that's the number of clinical red alarms. By the way, that was a very interesting case, which led to 2 patient deaths before we even started working. So the diagnosis, excuse me, the diagnosis needs to be based on data and facts, some of which you can get from merely looking at the alarm data. Those are the white ones over here. But there are some things that you don't get by just looking at alarm data, where you need to do an observation, where you need to shadow staff, where you really need to do a workflow analysis if you want to be comprehensive and really make sure that you covered all of the possible root causes that contribute to the alarm situation being the way it is. Which is why in our projects we use 4 diagnostic instruments. Invariably, we do alarm data analysis, we do workflow analysis, we do a staff questionnaire, and we do a semi-structured interview with staff. And of course, the art lies in consolidating the results from the 4 sources into a holistic picture of what goes on at the unit. Alarm data analysis is kind of an arcane science. There's not many people that are able to do that. But if you really have the figures, and if you show something like this chart of the alarm load per time of the day to nurses, they will be readily explaining you that all the peaks here, in particular the peak in the red alarm in the early morning, are related to routines at the unit, drawing blood, basic care for patients, ward rounds, that kind of thing. And you already got a hint on where you need to be looking to explain those peaks in the alarm load per time of the day. So alarm data analysis is something that is very helpful, that you can't do without, but of course the results thereof always need to be consolidated with the results from workflow analysis and interviews. Let's switch from the diagnosis to the therapy part. Again, the interventions that you do to improve the situation need to be targeting the diagnosed problems. I mean, again, that's a trivial thing to say, but here I highlighted the ones that have to do with workflow and processes and with the team and the warm bodies within, because they are the most important ones, but they are also the most hard ones to do. If we look at the list of interventions that we did in a single unit in one of those alarm redux hospitals, you will see 2 things. A, it's a long list, and B, the important ones are the ones that have to do with creating awareness, increasing the team engagement, change the workflows, change people's attitudes, make them aware of what they're doing, improve the communication within the team, and break old habits, long established habits. That's the main thing. Without that, you won't be successful in any alarm improvement project. Let me just jump to the current situation that we're in. That's a COVID-19 situation. In COVID-19, you will see an increased number of isolated patients. What do we do with in this situation? Of course, COVID is a huge epidemiological and also technological experiment, but at least there are some recommendations. A, for isolated patients, it is extremely important to understand that by reducing the sensitivity of your alarm chain, you may increase patient safety. It sounds paradoxical, but of course, if you have too tight alarm limits, you will increase the number of non-actionable alarms, and in particular for isolated patients, here the burden to acknowledge the alarm, to adjust the alarm limits is even higher. So you might consider to define an isolation profile for those patients to ensure that the alarms that get through are really actionable ones. It also might be a smart thing to change the policy with regard to acknowledging alarms from the central station, from the for isolated patients. But again, here you need to ensure that people are really compliant with a policy. COVID patients to a high degree will be ventilated patients of advanced age in isolation. So we have 3 factors contributing to the development ICU delirium right then and there. You need to make sure that you don't add other contributing factors. So you should make sure that you avoid alarm bursts, situations where you have 30, 40, 50 alarms per patient within 1 hour. I've seen alarm bursts of more than 180 alarms per hour. And of course, you should think about reducing the bedside alarm volume to at least not create a situation where you have 24/7 alarms beeping and disturbing the patient's circadian rhythm. If you can ensure this, you should be striving for a situation where you can do the alarm-related task, in particular alarm acknowledgement, adjustment from the enter room, not having to enter the patient room to do something like that. Another thing that COVID brings is not only isolated patients, but pop-up ICUs or makeshift ICUs. They come in different flavors. So if you have an open-based situation like this one here, it's perfectly clear that alarms and noise from alarms will be an issue for patients and staff alike. Here I can only recommend that you either institute something like an alarm watcher, or, which might be the smarter choice, you think about alarm distribution. Distributing the alarms to mobile devices carried by the caregivers can certainly reduce the noise from alarms, can also reduce stress from alarms. There have been quite some promising studies on this out there. If you have a container site, you should think whether bedside alarms are audible to begin with. If they're not, then reducing the bedside alarm volume to something like near 0 might be a smart thing. And again, here alarm distribution to mobile devices might be the intervention of choice to avoid a situation where alarm keeps ringing and ringing and nobody reacts to them. Of course, when you did an alarm improvement project, as with any intervention, you need to do a follow-up and a control. Not only do you need to do a pre-post comparison of all the parameters of all the KPIs that you've set, and as I said, alarms per monitored bed day might not be the smartest choice of KPIs. But you should also do other things. You should at least try to establish which of the intervention was responsible for which effect. And you should, and that's a must, make alarm management a recurring topic. An alarm improvement project may be over, but alarm management is never done with. It needs to be on the minds of people. So you need to have regular feedback to staff, establish KPIs, and do something like an alarm management work group, alarm experts, however you want to call it, to ensure that it is a constant quality topic like any other quality topic that you might have on your ICU, whether that's hygiene, sepsis, fall prevention, whatever. There are some take-home messages from this. I'd start with, there is no silver bullet. There is no single therapy that can solve the alarm problem, and you need to have a good diagnosis before you initiate any therapy on the disease, quote unquote, alarm fatigue. This diagnosis should not be based on your subjective impression, but must be fact-based and rely on data that you gather up front. And this is something, believe me, I learned it the hard way. There is no magic. If you uncover 5 problems in the alarm management and you decide to address 3 of them, rest assured the 2 remaining ones won't solve themselves just magically. You need to address them. And here, the most important thing that you might choose not to address is desensitization. If you improve the consumables, the configuration, the workflow, whatever, but you still have staff desensitized to alarms, the situation might become even more dangerous, because your alarms were non-actionable. Now they become more actionable. And if staff is still desensitized, you might see an increase in complications and situations that you want to avoid. It's the behavior stupid. Changing the configuration, changing consumables is an easy thing to do, but almost never will you be successful if you don't change people's attitudes, people's behavior, people's processes. And this is, as we all know from ourselves, the hardest thing to accomplish. There might be some side effects from your interventions. You should be closely monitoring the alarm system quality even during the intervention to detect those side effects and mitigate them. And finally, almost finally, it's never done. If you improve the alarm management, it needs to be a constant, a recurrent topic. You should have something like an alarm council that gets information about the alarm system quality. And finally, I need to emphasize, bad alarm management is not the fault of the nurses. It's the situation that they're working in that has to do with suboptimal layout, suboptimal machinery, suboptimal consumable, suboptimal processes. It's not their fault, but still they're at the heart of the matter if you want to get to a solution. Whenever you have a successful alarm management project, it is always a team effort driven by nurses and physicians alike, but the nurses are at the heart of the matter. They're not guilty of the bad alarm management, but they are the lever that you have to improve it and make it good. And that was my final message. Thank you so far. And now I'm open to take whatever question you have. And I'm sure there are many.
Thank you very much, Dr. Dirk. Now, I have a hospital which I work in, and it's a private hospital. And I'll be honest with you, the alarms are on all the time. And I don't know how the staff manage to work there, but pretty much gather from the fact of the behavior that for them they're so desensitized they don't even bother to turn it off now. Now I think that my own personal take about things is that the alarm is not an intervention. It is just a monitor, and if the alarm limits are not established correctly for each individual patient, it has limited utility. I would like to ask you, given your areas of interest and research, do you think there's any artificial intelligence that we can develop, or is there already in the works in Philips, for example, that can help
Oops. Are you still with me?
I think we hung there temporarily. Dr. Dirk, I'm just going to repeat my question. So I work in a unit in a private hospital. One of the units has its alarms on all the time. And I think that it's probably because of the limits that have been set inappropriately. They do not individualize the alarm limits for each patient. I think that alarm is only useful when it's set to the appropriate physiological limits for individual patients. And my question to you is, given your area of research and as well as where you work, has there been any advances or any progress in terms of using artificial intelligence to develop appropriate physiological limits for alarms to be more effective?
Yes, there are a lot of projects that look into that direction. It needs to be understood that in order to do that, you need a lot of information, not only about the patient when the patient is being admitted, but obviously the current therapy, whatever change of therapeutic regime you have. So the AI needs to be fed with data that goes far beyond patient sex and age and procedure and initial diagnosis, right? So a monitor as it is in the unit right now, it doesn't have that information. The monitor doesn't even know whether the patient's being ventilated or not. The monitor doesn't know whether the patient is on inotropes or not. But of course, all these factors play into what smart and adequate alarm limits should be. So I think we will be seeing systems that can be used in routine that have a better understanding of what the alarm limits should be, but they need to be fed with data from the EMR or PDMS or whatever electronic system you have that is informed about much more details regarding the patient. Because if you just start with age, sex, and main diagnosis, that won't help you very much. In some cases it is, like if you have a COPD patient, it might be a smart thing to change the SpO2 limits, but that's not something you need AI for, right? You know, the patient comes with an SpO2 value of 80, 85 in your unit. So that's here, the smart thing would not be to use AI, but rather to follow the idea of adjusting the alarm limits upon admission of the patient. So the answer to that is yes, but it won't be anywhere soon if we just use monitor information. We need information from the EMR or the PDMS. Otherwise, it won't make sense.
So I would summarize to say probably it needs more data points. Am I correct? And then
Yeah,
after that, with all
definitely.
the data points, then I guess you can machine learn. I guess
Yeah,
you are
definitely.
somewhere away. Is there anything in where you work right now in Philips? Any advances that you could tell us potentially is being developed?
Yeah, I mean, one of the things is, and again, that's a trivial thing. Every clinician knows that just by looking at the current value of a certain physiological parameter doesn't give you much information, right? If you look at the monitor as it is, you see a value that doesn't help you very much. We all know that we need to look at the trends. We need to look at patterns of physiological parameters changing in a way that is indicative of a certain form of deterioration. And the time snapshot of a single parameter, as is any threshold alarm, doesn't solve that problem. So yeah, we're looking into how can you, and we're looking at multi-parameter alarms. We're looking at defining patterns of changes in physiological parameters that indicate a certain type of deterioration to come up with smarter and in particular predictive algorithms. There are some very interesting publications that show there, like one I always like to show because there are so clear patterns in the parameters. There's 3 different ways how people die unexpectedly from respiratory causes on an ICU. 3 different ways. So it would be smart to detect those patterns and in a predictive manner alarm that something is going on, even though the single parameter did not yet reach a certain threshold. These are things that we're looking at, looking more holistically, looking in a multi-parameter over time way. There is a feature in Philips as in other monitors as well that allows you to define that. But of course here, certainly machine learning should come to our help and help us identify those patterns and come up with definitions that apply to the patient population that you're serving.
I see. Well, we all know that technology is progressing rapidly, and I'm sure what you have described will come on. In the meantime, I guess we will have to default down to human training, communication, team building, and the more traditional methods of addressing alarm fatigue. I'm wondering from your research whether there are any policies that you think would be useful. I bring this up because, as I mentioned before, the unit that I had experienced, they tell us that they were not allowed to turn off the alarms. They just let it ring and ring and ring and ring. And they were not allowed to silence it because it's part of the Joint Commission initiative or JCI policy that they are not allowed to turn any alarms off. My counter argument to them was that if you were to have the alarms on, but you're not responding to it at all, it serves no purpose either. So is there any policy guidance that you think are useful what to consider?
Yeah, the number one thing I'd like to get into the heads of people is that monitoring a patient is something that needs an indication. So in the best of all worlds, and I know this is a rosy picture, in the best of all worlds, upon admission of a patient, the nurse and the physician would make a conscious decision. What's the patient status? What's the likely patient trajectory? Where's the patient going to develop into? What are the risks that we need to monitor? What are the things, that's the important part, what are the things that we do not need to monitor? Which are the parameters that we should be measuring? And which of those parameters that we are measuring in the monitor we should set alarms on? So make a conscious decision on who is this patient, what are the risks this patient is at, so what is it that we need to be monitoring, and then set the parameters and the alarms accordingly. I know this almost never happens. What happens, in fact, is that the patient is admitted and every patient on the unit is monitored with the same set of parameters. That's the standard profile, right? But if you get it into the heads that monitoring is something that needs an indication and a conscious decision on what to monitor, that's the number one change in mindset that makes people think about what are they doing. That's the one thing. Then regarding policy, I don't think it's a smart thing to establish a policy or a guideline regarding monitoring from the top. What we've been doing is the following. We assembled a number of people from the unit, physicians and nurses alike, and said, okay, write down the 5 to 10 things that you think should go without saying for monitoring and alarm management, the trivial things. And from the responses here, we created the 10 commandments of alarm management that is individual to this unit. It reflects their beliefs, it reflects their safety culture, it reflects their way of collaboration. So having the team create their 10 commandments or 20 golden rules, whatever you want to call it, has a great effect on team culture because people become aware, people start discussing how should it be, how should we do alarm management. And when we have consolidated all those responses, it's not the Philips, it's not the JCI, whatever, it's their rules, it's their 10 commandments. They have established it because they will be the ones who have to enforce it. So why not have them define it? So this is an approach that I found very productive, very helpful, and it creates the right team spirit, and it is really inspirational because it starts people or makes people start thinking about alarm management, and whatever you come up with, it's their solution and they will be motivated to enforce it.
I see. I'm just thinking here, and the thought has always been in my mind, but I've never really met the person who might be appropriate in instituting it. And you sound like the right person. So I'm going to pitch you my idea. My idea is that there are a lot of algorithms in the critical care. It's made simple, such as Fast Hub BID. It's just basically a reminder for people to do certain things in a critical care setting in order to make sure that we do not miss small basic things that may make a big difference to the patient's care. We also have surviving sepsis campaigns, and we have this American thing called Choose Wisely as well as in the UK to make sure people remember and be cognizant about what they're doing and what they're choosing and the implications on cost. Do you think that there is a value maybe for Philips to drive this thing called, I don't know, choose alarms wisely or alarm awareness or alarm, basically to come up with an algorithm or sort of like a guidance and a campaign that's to drive through people to do exactly what you just said, to come up with a system of choosing maybe the top most important 8 to 10 variables that must be monitored and make it into a routine such that, perhaps not all patients require hourly urine output monitoring, not all patients require blood sugar monitoring every 2 hours, so that we could then better allocate resources in getting signals which are important as opposed to just having many data points.
I think, so if I were the head of Philips, the single one thing I'd like to get Philips doing would be the following. Whenever we deliver a monitor to a site, there are no predefined settings for alarm values, alarm thresholds. So whenever, as I said before, whenever you start monitoring a patient, you need to make a conscious decision. What is it that we need to monitor? I know this would make people crazy in the beginning because they need to think. Certainly it would be in emergency mode, but in routine, they need to think. They need to make a conscious decision, and they need to document that decision by setting alarm limits and selecting parameters. Which are the parameters that we need to need to monitor? So this would be something I would at least run an experiment on, and I know about a competitor who has exactly that setting. So that would be one thing that we'd like to do. When it comes to defining sets of parameters that make sense, I'm a bit hesitant because the breadth of clinical situations that our monitors are being used for is overwhelmingly large. And I would always leave it to the competency of people and also to their safety culture. Right. So if you ask two physicians for a single case, which are the parameters you should monitor? I mean, you will get an 80% agreement or 90% agreement on what should be monitored. But the interesting thing is the remaining 10% where people could discuss half an hour about whether they should be monitored or not. And I don't think Philips should be prescriptive in that sense that we say this is what should be monitored. What we should do is enforce that people start thinking when they start monitoring. It's not a mindless thing that you do when a patient comes to an ICU. ICU means monitoring, so let's monitor this guy. It needs to be a conscious decision, and starting this conscious process of making up their minds, that's something we should be enforcing.
Okay, totally agree. I mean, I always feel that manpower, brain power has a limited bandwidth. So it is always best that we're able to think now in order to increase bandwidth as opposed to just use all the bandwidth and have no space to think.
Exactly. So the typical argument would be we don't have the time. And I would say if you invest that time upon admission, and whenever the patient status change, you will re-up time benefits because you don't need to take care about so many non-actionable alarms. Exactly that.
Okay.
And there are situations where I always think, let me give you an example. I've seen alarm bursts of, as I said, more than 180 alarms in a single hour from a patient, and all of them were technical alarms, ECG electrode off. So obviously that was a hyperactive, agitated patient who always fiddled off the ECG electrodes and the SpO2 sensors. Now, I started asking people, if you have 180 alarms, ECG electrode off, what does that do with the patient? Will it make the patient more agitated or less agitated? But the most important thing is, do you still think that you have valid ECG monitoring? Because you don't, right? So take a step back and think about what should you be doing with that patient. 180 alarms per hour over the course of more than 3 hours. We're talking about hundreds of alarms. It drives everybody crazy, right? It drives the patient crazy. It drives staff crazy.
Crazy, yeah.
So step back and start thinking. in order to get a quiet ICU and reduce your cognitive stress. But we all know, I mean, we're humans, right? In particular in a busy ICU, you live from minute to minute, from second to second. But having that kind of timeout, what am I doing with this patient, would be a helpful thing to do. But again, that's behavior change and attitude change. That's the hardest to implement.
Yes, it is. Technology is easier to develop than to change human behavior. Okay,
Exactly.
With that, I thank you very much, Dr. Dirk.
You're welcome.
Thank you for your time. I've learned quite a bit from you. And again, we would like to thank Philips for sponsoring this track. We appreciate the help that you have provided us in making healthcare better. So we'll go into our break right now.
It was a pleasure.
Yeah, thank you. Bye.
Thank you. Bye.